Hello all. So today we are finishing up chapter 5 and talking about dietary fats and cholesterol and the health implications. As noted in previous chapters, the etiology of chronic diseases such as cancer and coronary heart disease is complex and involves multiple risk factors. Eliminating or reducing as many risk factors as possible is the best approach to optimize your health. Your diet is one of the most important risk factors that can be modified to promote good health, particularly the amount and composition of fat you eat. Every few years, the American Dietetic Association provides a review of the evidence regarding various dietary practices and effects on cardiovascular disease. In this section, we shall focus on the role of dietary fat in the etiology of coronary heart disease. And in Chapter 10, we shall discuss the possible role of dietary fat in obesity and related health problems such as diabetes, high blood pressure, and various forms of cancer. CHD is still the number one cause of death in industrialized nations. In its recommendations regarding dietary fat, the National Academy of Sciences indicated that although very high-fat diets may predispose to CHD, so too may very low-fat diets. For example, Siri and Krauss reported that increased dietary carbohydrates, particularly simple sugars and starches, with high glycemic index can modify the serum lipid blood profile in ways that may also be conducive to CHD, or coronary heart disease. Lipid expert Penny Chris Etherton and her associates recently noted that the main message regarding dietary fat is very simple. Avoid diets that are very low and very high in fat. The guiding principle is that moderation on total fat is the defining benchmark for a contemporary diet that reduces risk of chronic disease. Moreover, when within the range of a moderate fat diet, it is still important to individualize the total fat prescription. Fats are not all equal. Some are better for you than others, and as noted, the terms good and bad fats have been popularized. Remember, however, that even some bad fats can fit into a healthy diet. The key is moderation. So how does cardiovascular disease develop? Coronary heart disease is the major disease of the cardiovascular system. Of the million deaths noted previously, it is responsible for more than half. Although the total percentage of deaths due to coronary heart disease has been declining in recent years, it is still an epidemic and the number one cause of death among both males and females. Because the available evidence relating dietary lipids to cardiovascular disease is so compelling, we shall treat this subject in some detail. However, note that the dietary and exercise recommendations advanced later in the chapter for the prevention of cardiovascular disease may also prevent other chronic diseases such as obesity and certain forms of cancer. Nearly 1 out of every 2 deaths in the United States is due to diseases of the heart and blood vessels. Each year, approximately 1 million Americans die from some form of cardiovascular disease, including coronary heart disease, stroke, hypertensive disease, rheumatic heart disease, and congenital heart disease. Here you'll see the heart and the coronary arteries. The heart muscle itself receives its blood supply from the coronary arteries. The main coronary arteries are the left coronary artery, one of its branches named the circumflex, and the right coronary artery. Atherosclerosis of these arteries leads to coronary heart disease. Coronary heart disease, or CHD, is also known as coronary artery disease because obstruction of the blood flow in the coronary arteries is responsible for the pathological effects of the disease. The coronary arteries, which nourish the heart muscle, are in figure 512. The major manifestation of CHD is a heart attack, which results from a stoppage of blood flow to parts of the heart muscle. A decreased blood supply, known as ischemia, will deprive the heart of needed oxygen. In some individuals, ischemia results in angina, a sharp pain in the chest, jaw, or along the inside of the arm, indicative of a mild heart attack. Other terms often associated with a heart attack include coronary thrombus, which is a blockage of a blood vessel by a clot or thrombus, coronary collusion, which simply means blockage, and myocardial infarct, death of heart cells that do not get enough oxygen due to the blocked coronary artery. The major cause of blocked arteries is atherosclerosis. Arteriosclerosis is a term applied to a number of different pathological conditions wherein the arterial walls thicken and lose their elasticity. It is often defined as hardening of the arteries. Atherosclerosis, one form of arteriosclerosis, is characterized by the formation of plaque and accumulation of fatty acids, oxidized LDL cholesterol, macrophages, which are white blood cells that oxidize LDL, foam cells, which are macrophages that consume cholesterol, cytokines, the immune system mediators of inflammation, cellular debris, fibrin, and calcium on the inner lining of the coronary artery wall. A cap of smooth muscle cells forms around the plaque to prevent contact with the artery wall. 513 presents a schematic of the content of an arterial plaque. Oxidized LDL, cholesterol, and all of the others collect beneath the endothelial cells lining the coronary artery. The site of the plaque may be initiated by some form of injury to the cell lining, possibly an ulceration, which is what's shown here. Atherosclerosis is a slow, progressive disease that begins in childhood and usually manifests itself later in life. Because of its prevalence in industrial society, scientists throughout the world have been conducting intensive research to identify the cause or causes of atherosclerosis and coronary heart disease. The actual cause has not yet been completely identified, but considerable evidence has identified factors that may predispose an individual. As noted previously, a risk factor represents a statistical relationship between two items such as high serum cholesterol and heart attack. This does not mean that a cause and effect relationship exists, although such a relationship is often strongly supported by the available evidence. The three principal risk factors associated with CHD are high blood pressure, high serum cholesterol levels, and cigarette smoking. Several major professional and governmental health organizations also believe that physical inactivity is a fourth principal risk factor. Other interacting risk factors are heredity, diabetes, diet, obesity, age, gender, and stress. Elevated blood levels of homocysteine and C-reactive protein, or CRP, have been associated with CHD, and their role as a risk factor continues to be studied. Homocysteine is discussed in Chapter 7, and CRP is a marker for inflammation. And this is just a cool website. It's a questionnaire to assess your risk of developing coronary heart disease. It's important to know your cholesterol levels and blood pressure, but other risk factors also presented. So, how do the different forms of serum lipids affect the development of atherosclerosis? In atherosclerosis, the plaque that develops in the arterial walls is composed partly of fats and cholesterol. Hence, high levels of blood lipids such as triglycerides and cholesterol are associated with increased plaque formation. However, as you recall, triglycerides and cholesterol may be transported in the blood in a variety of ways, but primarily as constituents of lipoproteins. Considerable research has been devoted to identifying those specific lipoproteins and other lipid components that may predispose to CHD. And although there's some debate about the meaningfulness of specific serum lipid profiles, some theories prevail. The four main serum lipid factors associated with increased risk of atherosclerosis are total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. The guidelines for the fasting blood serum level profile recommended by the National Cholesterol Education Program are presented here in Table 5.7. The major villain appears to be serum cholesterol. Total cholesterol, expressed in milligrams per 100 milliliters of blood, is a significant risk factor. A cholesterol level below 200 is considered to be desirable. Between 200 and 239 is borderline high, and above 240 is high. However, you should be aware that there is a rather large standard error of measurement involved in some tests of cholesterol, being on the order of 30 milligrams. What this means is that if your blood cholesterol is reported as 220, which is borderline high, you may actually have a cholesterol level of 190, which is still desirable, or 250, which would be high. If you vary respectively one standard error below or above your actual measurement of 220, for this reason, it may be a good idea to have a second test completed if you're concerned about your total cholesterol level. The form by which cholesterol is transported in your blood may be related to the development of atherosclerosis. In general, a high level of low-density lipoproteins, or LDL, is the major risk factor associated with atherosclerosis. A current theory suggests various forms of LDL, such as small, dense LDL and the variant lipoprotein A, and may be more prone to oxidation by macrophages at an injured site in the arterial epithelium, leading to an influx into the cell wall and the formation of plaque. The presence of oxygen-free radicals has been suggested to accelerate this process. Other mechanisms, such as increased clotting ability, may be operative. LDL levels less than 100 are optimal, while those above 160 pose a high risk, and those above 190 are very high risk. Although not normally listed in risk factor tables, lipoprotein A values greater than 25 to 30 milligrams per deciliter of blood are associated with increased risk of CHD. A high level of LDL, which is some consider a form of, a high level of IDL, which some consider a form of LDL, is also recognized as a risk factor, as it is apolipoprotein B, involved in cholesterol transport to the tissues. Conversely, high levels of HDL, or high-density lipoproteins, particularly the subfraction HDL2 and HDL with apolipoprotein A1, appear to be protective against the development of atherosclerosis, although research is continuing to explore other relationships. Levels of 60 milligrams or more of HDL appear to be protective, but because HDL varies daily, several measurements over time may be required to obtain an accurate reading. Research suggests that HDL interacts with the arterial epithelium, acting as a scavenger by picking up cholesterol from the arterial wall and transporting it to the liver for removal from the body, known as reverse cholesterol transport. HDL may also inhibit LDL oxidation and platelet aggregation. HDL2 levels are higher in women until menopause and then decrease with an associated increased risk for CHD. Jacobson and others noted that elevated triglyceride levels may be a significant independent risk factor for coronary heart disease. Also, it is often associated with increased levels of LDL, particularly the small, dense LDL, and decreased levels of HDL. Current guidelines from the National Cholesterol Education Program indicate that triglyceride levels below 150 milligrams per deciliter are normal, whereas the risk associated with progressively increasing levels goes from borderline high to very high. Jacobson and others indicate increasing concern over the increasing rate of hypertriglyceridemia, which is associated with overweight and obesity. This is a summary of serum lipid factors associated with the increased risk of atherosclerosis. Cholesterol ratios and other tests. If your total blood pressure or total blood cholesterol is borderline or high, a determination of the LDL and HDL levels may be desirable, for they provide additional information relative to your risk. Based on epidemiological data, several ratios have been developed to assess risk of CHD. With the lower the ratio, the lower the risk. One common comparison is the ratio of total cholesterol to the HDL level, or TC divided by your HDL. A ratio of about 4.5 is associated with an average risk for CHD. For example, an individual with a total cholesterol of 200 and an HDL of 60 would have a ratio of 3.33, or a lower risk, while someone with a total cholesterol with the same total cholesterol but an HDL of 20 would have a much higher risk with a ratio of 10. So another comparison is the ratio of LDL to HDL, or LDL. An LDL to HDL ratio of about 3.5 is considered to be an average risk for CHD. Thus, a ratio of 140 over 60, or 2.3, would be a much lower risk than 140 over 20, or 7. Additional tests are merited for those at high risk for CHD. Special lipoprotein tests may measure density levels of the various lipoproteins. Tests for other markers of atherosclerosis, such as homocysteine and CRP, will add to the diagnosis. For example, Ridker and others noted that high CRP levels may be more effective predictors of heart attacks than high LDL cholesterols, but the greatest risk is when both are high. The National Cholesterol Education Program indicated that individuals at high risk for cardiovascular disease may consider getting their LDL levels as low as possible and could explore with their doctor the possibility of taking lipid-lowering drugs. Table 5.9 provides some guidelines. However, even if on drug therapy, individuals should not abandon a healthy lifestyle. Can I reduce my serum lipid levels and possibly reverse atherosclerosis? Lowering your serum cholesterol, particularly your LDL cholesterol, is a very effective means to help prevent CHD. La Rosa indicated that for each 1% reduction in LDL cholesterol, there is a corresponding 1% reduction in coronary heart disease. Several approaches may help you improve your serum lipid levels and reduce the risk of atherosclerosis. A healthy lifestyle is one, and appropriate drug therapy is another. However, even with a healthy lifestyle, some individuals may have poor serum lipid profiles. Certain forms of hypercholesterolemia are genetic. In the future, gene therapy may be the treatment of choice for such individuals, possibly manipulating genes to decrease LDL and increase HDL. Currently, drug therapy may be required to reduce serum lipid levels in genetically predisposed individuals, as well as in those with poor diets. Some drugs stimulate liver degradation and excretion of cholesterol. Others increase lipoprotein lipase activity or LDL receptor function to decrease serum triglyceride levels, while still others bind with bile salts in the intestines so that they are not reabsorbed. Because bile salts are derived from cholesterol, it is effectively excreted from the body. Statins, drugs that inhibit an enzyme, HMG, CoA, reductase that regulates cholesterol, have been particularly effective to reduce serum LDL cholesterol. Adopting a healthier lifestyle is the first step in attempting to improve one's serum lipid profile. A healthy lifestyle may not only help to prevent the development of atherosclerosis, but also lead to regression of coronary artery blockage. For those who are interested in preventing the development of atherosclerosis or reversing its progress, an appropriate diet and exercise program, as discussed below, are two key elements of a healthy lifestyle that are recommended by health professionals. Both factors may have favorable effects on not only on serum lipid levels, but on other risk factors for CHD as well, such as obesity and hypertension. Several health organizations, including the American Heart Association, the National Institutes of Health, and the National Heart, Lung, and Blood Institute, have recommended a number of dietary guidelines that have been shown to lower serum cholesterol or serum triglycerides. Moreover, recent studies using the DASH or dietary approaches to stop hypertension and OmniHeart or optimal macronutrient intake for heart health diet plans have also helped refine dietary recommendations for healthy eating. Based on the available scientific evidence, the following guidelines appear to be prudent and are consistent with the National Academy of Sciences recommendations for dietary fat. Although these guidelines have been developed to help individuals reduce high serum lipid profiles, they will help to maintain normal levels and thus may be regarded as preventative medicine. As you may note, these recommendations are extensions of some guidelines for the prudent healthy diet. Each guideline may be used to select foods that appeal to personal tastes. Individuals are more likely to eat a healthful diet if it includes foods they enjoy. It should be noted that in the near future, the application of nutrigenomics may permit individualized dietary recommendations. Menus may be tailored to the genetic profile of each individual to maximize dietary effects favorable to the lipid profile and prevention of CHD, as well as prevention of other chronic diseases. So what should I eat to modify my serum lipid profile favorably? The National Cholesterol Education Program was developed with the general goal of reducing the prevalence of high serum cholesterol in the United States. One of the first steps is to identify those individuals with high serum cholesterol by various simplified screening techniques, such as the measurement of total cholesterol by small samples of blood combined or obtained through fingertip capillary blood. If this measure is borderline high, 200 to 230 milligrams per deciliter, or greater than 240 milligrams per deciliter, venous blood samples may be taken to determine LDL and HDL levels. If serum cholesterol levels are detected, dietary modifications and other appropriate lifestyle changes may be recommended. This illustration here is the composition of the average American diet and the step 1 diet of the NCEP. Although the differences between the two diets appear to be small, such changes may reduce serum lipids. This that you see here is a sensible plan to monitor the effects of a cholesterol-lowering diet. The initial diet plan may involve the NCEP step 1 diet, but if unsuccessful, the step 2 diet may be implemented in individuals highly resistant to dietary modifications, and drug therapy may be prescribed. If the original dietary plan is not effective after several months, the step 2 NCEP diet may be recommended, which is essentially the same as the step 1 diet, but with less than 7% of the dietary calories from saturated fat and less than 200 milligrams of cholesterol per day. 2 meta-analyses revealed that the NCEP diet plan significantly decreased total blood cholesterol and may have multiple beneficial effects on major cardiovascular risk factors. This is just a representative expected changes in total serum cholesterol and LDL cholesterol associated with the appropriate dietary modifications, such as switching from the typical American diet to the step 1 diet of the NCEP. So you'll notice the reduction in total cholesterol as well as LDL cholesterol within 6 months of time. A few recommendations are dietary recommendations to reduce the risk of the CHD. Number 1 is to adjust caloric intake to achieve and maintain ideal body weight. One of the most common causes of high triglyceride levels is too much body fat, particularly in the abdominal region. The health risks of obesity are detailed in Chapter 10. In many cases, simply losing body weight or reducing caloric intake will reduce these levels. You can also reduce the total amount of fats in the diet. The American Heart Association recently increased the upper limit of dietary fat intake from 30% to 35%. Keep in mind that that is the upper limit. Reducing the total amount of fat will usually reduce the amount of calories, but nutrient content will actually improve. Reducing total fat intake to 20% or lower of total daily calories as recommended in some healthy diet plans will reduce total and LDL cholesterol even more. However, a very low fat diet, 10% fat calories, may actually cause a negative lipid profile in some individuals. To help prevent this, the carbohydrate calories that replace the fat calories should not be derived from refined carbohydrates, but rather from complex carbohydrates containing dietary fiber, so your fruits and your vegetables. However, for a style of eating to be effective at improving health, it must be sustainable. Gibson and others in their meta-analysis demonstrated that individuals on low carbohydrate, high fat ketogenic diets were less hungry, had a decreased desire to eat, and had a greater feeling of satiety and fullness. Over the long term, decreased appetite could lead to weight loss, which would improve cardiovascular health. Johnson and others recently analyzed 48 randomized weight loss trials with dietary fat intakes ranging from low fat, less than 20% of daily calories, up to high fat, 55% of total calories. They determined that the differences between the diets were too small to be important to affect weight loss. Thus, low fat or high fat was not an important factor for determining weight loss. However, long-term diet-induced weight loss studies are among the most difficult type of research studies to complete, and participants often have poor compliance to the dietary intervention. Because weight loss will only occur if the diet is maintained, the authors recommended that the diet that promotes the best adherence is the ideal diet. Another recommendation is to reduce the amount of saturated fat to less than 7% of dietary calories. The American Heart Association decreased the upper limit of saturated fat intake from 10% to 7%. As a matter of fact, scientists recommended reducing intake of saturated fats as low as possible while consuming a nutritionally adequate diet. The National Academy of Sciences indicated that there is a positive linear trend between total saturated fatty acid intake and total and LDL cholesterol concentration and increased risk of CHD. Saturated fats may also increase blood clotting, another risk factor for CHD. In 2 meta-analyses, Howell and others found that consumption of saturated fatty acids was the major dietary determinant of plasma cholesterol response to diet, while Clark and others indicated that reducing the intake of saturated fat produced the most significant benefits regarding the prevention of CHD. The effects of dietary fat intake on human health are extremely complex and not as straightforward as saturated fats are bad are bad and must be avoided. As an example, Volk and colleagues from Jeff Volk's lab placed obese volunteers on 3-week diets with dietary carbohydrate increasing from 46 grams per day to 346 grams per day, and saturated fat decreasing from 84 to 32 grams per day. Over the study, dietary saturated fat intake had no effect on the saturated fatty acid content of any plasma lipids. However, as dietary carbohydrate increased, palmitoleic acid, which is associated with poor health outcomes, also increased. This study, which showed no relationship between dietary and plasma saturated fat, but instead showed a potentially negative aspect of dietary carbohydrate in obese patients with metabolic syndrome. This highlights the complex relationship between diet and health. The same team studied the effects of 12 weeks of consuming 3 whole eggs per day versus a yolk-free substitute while on a low 25 to 30% of calories carbohydrate diet in patients with metabolic syndrome. Although both groups lost weight and improved certain aspects of metabolic health, the group consuming whole eggs improved more in some inflammatory markers, plasma insulin, VLDL, and HDL. This demonstrates that fat intake interacts with carbohydrate intake, body mass, weight loss, and existing metabolic disease. Ideally, you should reduce the consumption of trans fats, and comparable to saturated fat, keep dietary fat intake as low as possible. The combined total of dietary saturated and trans fat should not exceed 10% of daily caloric intake. The American Heart Association recommends much lower intake of less than 1% of energy from trans fats. In a review, Lichtenstein noticed that trans fats elevate LDL and at relatively high intakes decrease HDL. Some data suggest that trans fatty acids may also trigger inflammation. The National Academy of Sciences also noted that, like saturated fats, there is a positive linear trend between trans fat and CHD. Although some reviewers contend that the adverse effects of trans fatty acids are somewhat less than those associated with saturated fatty acids. Mazzaferran and others cited research indicating that they may be as bad or even worse. To decrease trans fat intake, you need to know what foods contain it. Although we know that meat and dairy products contain small amounts of natural trans fats, the Consumers Union has referred to as trans fats as the stealth fat because we may not realize it is in the foods we eat. The vast majority of trans fat consumed by Americans is in processed food, particularly margarine, vegetable shortening, white bread, packaged goods such as cookies, crackers, potato chips, and cakes, and fried fast foods such as French fries. The major component of each of these foods that adds trans fatty acids is usually partially hydrogenated vegetable oil. Trans fatty acid content per serving is now listed in the Nutrition Facts food label. However, the food label may list 0 grams of trans fat if there is less than 0.5 grams per serving. Thus, consuming multiple servings of such products daily may accumulate, totaling several grams or more of trans fat. In late 2015, the FDA decided that trans fat is not generally recognized as safe for use in human food and that manufacturers must remove partially hydrogenated oils from their products within 3 years. It's also recommended that you substitute monounsaturated fats for saturated fats and simple or refined carbohydrates. Consume about 10 to 15% of calories from monounsaturated fats. Although no DRI has been set for monounsaturated fats, the National Academy of Sciences notes that they may have some benefit in the prevention of chronic disease. Epidemiological research has indicated that the Mediterranean diet is associated with reduced risk of CHD. Olive oil, the primary source of dietary fat, is a staple of the Mediterranean diet. It is rich in monounsaturated fatty acids, is a good source of various phytochemicals, and contains the antioxidant vitamin E. Nevertheless, the FDA has approved a qualified health claim for olive oil, indicating that eating 2 tablespoons of olive oil daily may, due to its monounsaturated fat content, reduce the risk of CHD. Keep in mind that qualified health claims are based on limited, not conclusive evidence. Walter Willett, the renowned nutrition research scientist from Harvard University, reported that both epidemiological and metabolic studies suggest that individuals can greatly benefit by adopting elements of the Mediterranean diet. Although olive oil is one of those elements, others include a diet rich in vegetables, whole grain, and seafood, all of which may confer health benefits in the prevention of CHD. Dietary fats can have powerful effects on metabolic health. One recent example is from a study from Wang and colleagues in which obese individuals were placed on a low-fat diet, about 24% of energy from fat, a moderate fat diet, 34% of energy from fat, and a moderate fat diet with 1 Hass avocado per day, also 34% of energy from fat. After 5 weeks, the decrease in LDL was greater in the avocado group than in other moderate fat or the low fat group. Additionally, LDL particle number, small density LDL cholesterol, and LDL HDL ratio were all decreased in the avocado group. Avocados, olive oil, and nuts are rich sources of MUFAs. So it's a good thing because I eat my avocado once every other day. All right, consume adequate amounts of polyunsaturated fatty acids. As indicated previously, the National Academy of Sciences developed for an AI for both omega-6 and omega-3 polyunsaturated fats because there may be some health benefits associated with such dietary intakes. Both types of fatty acids help promote healthy skin and are a source of various eicosanoids that may influence health processes. When substituted for saturated fat, polyunsaturated fat may reduce total serum cholesterol, including LDL cholesterol. Polyunsaturated fatty acids should constitute about 10% of the daily caloric intake, and if foods are selected wisely, this should provide adequate amounts of both omega-6 and omega-3 fatty acids. The essential omega-6 linoleic fatty acid is found in various vegetable oils that constitute food products such as margarine, salad dressings, and cooking oils. Several sources are listed in Table 510. The essential omega-3 alpha-linoleic fatty acid is found in green leafy vegetables, canola oil, flaxseed oil, soy products, some nuts, and fish. Some nuts are especially rich in both omega-3 and omega-6 fatty acids. Although both essential fatty acids may confer separate health benefits, the omega-3 fatty acids are thought to be more important for the prevention of CHD. The omega-3 fatty acids, the principal omega-3 fatty acids are alpha-linoleic, EPA, which is eicosapentaenoic acid, and DHA, docosahexaenoic acid, are believed to reduce the risk of CHD, but EPA and DHA are believed to be more potent. EPA and DHA may be formed in the body from alpha-linoleic acid, but this process appears to be limited. However, both EPA and DHA are found in substantial quantities in various fish oils, as highlighted in Table 511. Eggs from chickens fed a special diet may contain DHA in amounts ranging from 0.05 to 0.15 gram, but the eggs are still high in cholesterol. Fish oil supplements may contain about 0.3 to 0.5 grams. As mentioned earlier, omega-3 fatty acids have been theorized to be ergogenic because of the production of specific eicosanoids. Omega-3 fatty acids are also being studied for their potential health benefits, which may also be related to specific eicosanoids that are produced. Although the health-related role of omega-3 fatty acids and eicosanoids is complex and has not been totally determined, here is a simple summarization. The cell membrane contains a variety of molecular compounds, including phospholipids and their associated fatty acids. When the diet is high in linoleic acid, one of the main fatty acids in the phospholipids is arachidonic acid, which produces one form of eicosanoids when it is metabolized. When the diet is high in fish oils, EPA and DHA become the major source of eicosanoids, which are different in nature compared to those derived from arachidonic acid. In essence, the different forms of eicosanoids function as local hormones in body cells, affecting metabolism and gene expression, and the effects associated with omega-3 fatty acid derived eicosanoids appear to provide some health benefits. Metcalf and others found that the dietary omega-3 fatty acids are rapidly incorporated into the phospholipids of human heart muscle cells, displacing arachidonic acid. Most research has focused on the effects of fish oil or omega-3 fatty acid supplementation on CHD, and the reviews of published studies are contradictory. The effects of fish intake on cardiovascular health is less controversial than research on the effects of saturated fat intake on health. Chowdhury found that fish consumption is associated with decreased risk of cerebrovascular disease such as strokes. This points to the beneficial effects of omega-3 fats on health. Epidemiological research has suggested that populations consuming diets rich in fish products have a lower incidence rate of CHD, and experimental research has suggested a number of possible mechanisms underlying this relationship. Those being to reduce serum triglycerides, increase HDL, the good cholesterol, prevent clot formation, decreasing platelet aggregation and stickiness, improving vascular tone, and decreasing blood viscosity, as well as optimizing blood pressure, promoting anti-inflammatory activities, and decreasing abnormal heart rhythms. Tufts University, one of the leading international nutrition research universities, noted that the predominance of the medical literature continues to support eating fish for cardiovascular health. Based on the available evidence, Chris Etherton and others provided some dietary guidelines on the American Heart Association's scientific statement: fish consumption, fish oil, omega-3 fatty acids, and cardiovascular disease. Key points are to eat fish, particularly fatty fish, at least 2 times a week. Fatty fish such as mackerel, lake trout, herring, sardines, albacore tuna, and salmon are high in EPA and DHA. Eat plant foods rich in the alpha-linoleic acid, an omega-3 fatty acid that may be converted into EPA and DHA in the body. And individuals who have high serum triglycerides may benefit from a fish oil supplement of 2 to 4 grams of EPA and DHA per day. Patients with CHD may benefit but should consult with their physicians. Although eating more fish and fish oils is a healthy recommendation, a report by the Institute of Medicine, Seafood Choices Balancing Benefits and Risks, raises some caveats. Some types of fish may contain significant amounts of mercury, as methylmercury, which, if consumed in excess, may harm the nervous system and impair neurodevelopment in the fetus or young children. Sushi is generally made from large bluefin or ahi tuna, which may contain mercury. Some types of fish, particularly older, large predatory fish, such as shark and farm fish, such as Atlantic salmon, may contain environmental contaminants such as dioxins and polychlorinated biphenyls. Although eating more fish and fish oils is a helpful recommendation, we've already talked about that. You may also see omega-3 fatty acids prominently displayed on many food labels, such as cereals, pasta, yogurt, and soy milk. However, check the ingredient list for the source. If it is soybean, canola, or flaxseed oil, the omega-3 fatty acid is alpha-linoleic, which is a good choice, but not considered to be as healthful as EPA and DHA. The health effects of low-level methylmercury in adults are not clearly established. Adults should consume a variety of seafood. Select fresh, local seafood where available. Some types of fish, particularly older, large predatory, and we've already talked about that as well. In a major review, Mazzafaran and Rim concluded that the benefits of fish intake exceeded the potential risks. However, along with the AHA, FDA, and Consumers Union, caution is recommended depending on a person's stage in life. For women of childbearing age, benefits of modest fish intake, excepting a few selected species, outweighs risks. The FDA indicates that pregnant women should limit the intake of shark, swordfish, king mackerel, and tilefish, and limit consumption of other fish to no more than 12 ounces per week. The FDA indicates that shrimp, salmon, pollock, and catfish are generally low in mercury, based on new FDA data showing that some canned light tuna may contain as much mercury as white albacore tuna. The Consumer Union recommends that women who are pregnant avoid canned tuna entirely. Women of childbearing age should also limit weekly consumption of canned tuna, no more than 3 6-ounce cans of light tuna or no more than 1 can of white tuna. Young children should also limit consumption of fish that may be high in mercury, including tuna. The Consumer Union recommends that young children who weigh up to 45 pounds should eat less than 1 can of tuna a week. Young children may also eat salmon, tilapia, shrimp, and clams daily, but should limit intake of other fish to several times a week or less. And this just gives you some recommendations for what you should eat daily and then several times per week. Environmentalists recommend choosing safe, sustainable fish such as wild Alaska salmon, canned pink or sockeye salmon, sardines, Atlantic mackerel, and farmed oysters as well. Although consuming fish is the recommended means to obtain EPA and DHA, fish oil supplements are also available. Weber and others noted that the possible higher mercury content of some fish may make the intake of omega-3 fatty acids as capsules the better choice. Mercury accumulates in the muscle of the fish, not the fat tissues that is the source of fish oils. Although some health professionals recommend higher amounts for individuals with high levels of serum triglycerides or heart disease. One recommendation for healthy individuals is 500 to 1,300 milligrams a day of EPA and DHA combined. This is more liberal than the recommendation from Lee and colleagues in their review. They propose at least 1 gram of long-chain omega-3 fatty acids daily for patients with known CHD and 250 to 500 milligrams daily for those without disease. The amount of EPA and DHA in typical fish oil capsules vary, but generally a 1,000 milligram fish oil soft gel will contain about 180 milligrams of EPA and 120 milligrams of DHA, or a total of 300 milligrams of omega-3 fatty acids. Consuming 2 or more capsules a day would provide the recommended amount. Some capsules may contain more than 500 milligrams of omega-3 fatty acids. However, Brunton and Collins note that many types of omega-3 fatty acid supplements are available, but the efficacy, quality, and safety of these products are open to question because they are not regulated by the same standards as pharmaceutical agents. Health professionals recommend that you discuss the benefits and risks of taking fish oil supplements with your doctor. If you do take supplements, do so with food to help absorption. You may also see omega-3 fatty acids prominently displayed on many food labels such as cereals, pasta, yogurt, and soy milk. However, check the ingredient list for the source. If it is soybean, canola, or flaxseed oil, the omega-3 fatty acid is alpha-linoleic, which is a good choice but not considered to be as helpful as the EPA and DHA. Conjugated linoleic acid is a polyunsaturated omega-6 fatty acid found naturally in small amounts in dairy foods and beef. It has been studied for its potential to reduce body fat. Wiggum and others conducted a meta-analysis of 18 human studies and concluded that CLA supplementation in a dose of about 3.2 milligrams daily produces a modest loss of body fat in humans, about 0.1 pound per week. Although this may be meaningful over time, the Consumer Union reports some research suggesting that CLA supplementation may induce some effects such as impaired blood glucose regulation and inflammation that may contribute to chronic heart problems. The role of CLA in weight control is discussed further in Chapter 10, but currently those at a risk for CHD may be advised not to use it. You want to limit the amount of dietary cholesterol. In recent years, some have contended that dietary cholesterol does not influence serum cholesterol in the development of CHD. For example, Hassler noted that it is known that there is little, if any, connection between dietary cholesterol and blood cholesterol, and consuming up to 1 or more eggs per day does not adversely affect blood cholesterol levels. In contrast, in a meta-analysis covering 17 studies that evaluated cholesterol intake for at least 14 days, Wegemans and others noted that the addition of 100 milligrams of dietary cholesterol per day would increase slightly the ratio of total cholesterol to HDL cholesterol, an adverse effect on the serum cholesterol profile. They concluded that the advice to limit cholesterol intake by reducing consumption of eggs and other cholesterol-rich foods may be still valid. Limiting cholesterol intake is particularly important for cholesterol responders, those individuals with a genetic predisposition whose body production of cholesterol does not automatically decrease when the dietary intake increases. The average U.S. daily intake is approximately 400 to 500 milligrams or more. Although some countries do not provide specific recommendations regarding dietary cholesterol, the United States government does, as do some health professional organizations. The amount specified in the daily value for food labels is 300 milligrams per day. The American Heart Association recommends a cholesterol intake of 300 milligrams per day or less, or 100 milligrams per 1,000 calories consumed. If you consume foods with artificial fats, do so in moderation. The fat substitutes discussed earlier in this chapter are generally recognized as safe and have been approved by the Food and Drug Administration. Although Olestra has been approved by the FDA, some contend that its use may interfere with the absorption of several fat-soluble vitamins and beta-carotene. However, the FDA requires that products containing Olestra-type fat substitutes be enriched with fat-soluble vitamins to offset potential losses. Snack foods containing Olestra, particularly when consumed in large amounts, may cause intestinal cramps and loose stools. The Center for Science and the Public Interest noted that the FDA received more than 18,000 adverse reaction reports from people who had eaten Olestra-containing foods. Sales of such foods have dropped dramatically. In its position statement, the American Dietetic Association concludes that the majority of fat replacers, when used in moderation by adults, can be safe and useful adjuncts to lowering the fat content of foods and may play a role in decreasing total dietary energy intake. However, the ADA notes that they are effective only if they lower the total caloric content of the food and if the consumer uses these foods as part of a balanced meal plan, such as the promoted in the 2010 Dietary Guidelines for Americans. Some fat is needed in the diet to provide the essential fatty acids and fat-soluble vitamins, and this fat should be easily obtained through natural wholesome foods such as whole grains, fruits, and vegetables. Following such appropriate guidelines, the American Diabetes Association indicated that foods with fat replacers have the potential to help people with diabetes reduce total unsaturated fat intake and may help improve the serum lipid profile. Another possible health benefit of fat substitutes may be their application in weight loss programs. You also want to reduce your intake of refined carbohydrates and increase consumption of plant foods high in complex carbohydrates and dietary fiber, particularly water-soluble fiber. Refined sugar and starches provoke higher triglyceride concentrations more than complex carbohydrates with fiber do. Again, the value of complex carbohydrates in the diet is stressed, particularly high-fiber foods, as a means to help reduce serum cholesterol. Research has suggested that without adequate amounts of fiber, a diet low in saturated fats and cholesterol has only modest effects on lowering CHD risk. Thus, replace high-fat foods with high-fiber foods. Legumes such as beans are an excellent source of carbohydrate and water-soluble fiber. Beans also contain protein and soy protein as found in products such as tofu. Has been shown to reduce cholesterol in men with both normal and high serum cholesterol. Oat products such as found in oatmeal may effectively lower serum cholesterol. Increased consumption of fruits and vegetables is recommended as well, for they may provide substantial amounts of the antioxidant vitamins C, E, and beta-carotene. They may help to prevent undesired oxidations in the body. Guidelines presented in the preceding chapter are helpful to increase carbohydrate intake, and the role of antioxidant vitamins is discussed in Chapter 7. Some plant foods, such as almonds and oats, may also contain various sterols and stanols, which are known to reduce serum cholesterol. Commercial margarines, such as Benecol and Take Control, contain plant stanols, and sterols. A diet rich in plant sterols and stanols may reduce the risk of heart disease. Plant foods also contain several phytochemicals that may reduce serum cholesterol. Many food manufacturers, such as those who produce breakfast cereals and orange juice, are fortifying their products with sterols, stanols, phytochemicals, and other nutrients, creating functional foods designed to reduce serum cholesterol and provide other health benefits as well. You want to nibble on food throughout the day. Interestingly, David Jenkins showed a significant reduction in serum LDL cholesterol if subjects consume their daily calories, actually the same food, throughout the day rather than in the 3 concentrated meals at breakfast, lunch, and dinner. In particular, it may be wise to avoid eating a high-fat meal. Nichols and others reported that a single meal rich in saturated fats may impair blood vessel function and reduce the anti-inflammatory potential of HDL cholesterol. The Consumers Union noted that a single high-fat meal significantly increased serum triglycerides and decreased blood flow through the heart. Jakulja and others found that a single high-fat meal could increase the blood pressure response to a stressful situation, such as public speaking. All of these factors may increase the short-term risk of a heart attack in susceptible individuals. It is best to focus on an overall healthy lifestyle that includes adequate amounts of physical activity, acceptable levels of physical fitness, proper weight management, and a diet that is not extreme in terms of the intake of specific nutrients. You should not eliminate all fat from your diet, but simply reduce the amount of fat that you eat. In essence, eat less butter, fatty meats, organ foods such as liver and kidney, egg yolks, whole milk, cheeses, ice cream, gravies, cream foods, high-fat desserts, and refined sugar. Eat more very lean meats, fish, poultry, egg whites, skim, and low-fat milk products, fruits and vegetables, beans, and whole grain products, or the prudent healthy diet. This table 512 provides some specifics. Here's some more specifics for you. Can an exercise training also elicit favorable changes in the serum lipid profile? Physical inactivity or lack of exercise has been identified as one of the primary risk factors associated with an increased incidence of atherosclerosis and cardiovascular disease. Hence, exercise programs stressing aerobic endurance type activities have been advocated as a means of reducing the incidence levels of these conditions, possibly via direct beneficial effects on the heart or blood vessels. However, the precise mechanism whereby exercise may help reduce the morbidity and mortality of CHD has not been identified. Therefore, many authorities believe that the beneficial effect may not be due to exercise itself, but rather the possible associated effects, such as reductions in body fat and blood pressure. Although some investigators believe that endurance exercise may have a preventative function independent of these associated effects, it also exerts a significant beneficial influence on the serum lipid profile, which, like blood pressure, is one of the major risk factors. Chronic exercise training has been shown to affect favorably the serum lipid profile. Hundreds of epidemiological and experimental studies have been conducted over the past several decades to investigate the effects of exercise on serum lipids. In general, increased levels of exercise are associated with lower plasma levels of triglycerides and higher levels of HDL. As documented in several recent meta-analyses by Kelly and Kelly, moreover, research has shown that exercise may not improve the lipid profile of some individuals, primarily in those with genetic defects. These individuals may receive other health benefits of exercise, but may need drug therapy to control elevated serum lipid levels. An acute bout of exercise may reduce risk factors for CHD. For example, Thompson and others recently noted that acute exercise may reduce blood pressure and serum triglycerides, increase HDL cholesterol, and improve insulin sensitivity and glucose homeostasis. Thus, some of the beneficial effects of exercise on risk factors for CHD, including the serum lipid profile, may be attributed to recent exercise bouts. However, some of these benefits may become long-lasting with a chronic exercise training program. In an attempt to quantify the serum lipid changes with the amount of exercise, Durstein and his associates conducted a meta-analysis of well-controlled studies. One of the dose-response findings from their analysis indicated that an exercise training volume of about 1,200 to 2,200 calories per week is often effective at elevating HDL level cholesterols from 2 to 8 milligrams per deciliter and lowering triglyceride levels by 5 to 38 milligrams of deciliter. Their analysis also suggests that greater increases in HDL cholesterol can be expected with additional increases in exercise training volume. This amount of physical activity is reasonable and attainable for most individuals and is within the ACSM recommended range for healthy adults. Lifetime aerobic exercise appears to be the key, and moderately intense leisure time activities such as brisk walking may elicit beneficial effects in men, women, children, and adolescents. As noted by Kelly and others, walking favorably affects the adult serum lipid profile independent of changes in body composition. And you see the same here. However, in women, extreme amounts of exercise combined with insufficient energy intake and leading to amenorrhea may reverse these benefits. The effects of exercise-induced amenorrhea will be discussed further in chapters 8 and 10, but it appears that the lower levels of estrogen associated with this condition may lead to lower levels of HDL cholesterol. As noted previously, a single high-fat meal may increase the risk of heart attack. However, Katsanos indicates that expending about 500 calories or more through moderate intensity exercise within 16 hours before the meal will minimize adverse changes in the lipid profile. As discussed below, this supports the finding that endurance athletes who consume diets rich in fat maintain normal serum lipid profiles. Research has revealed that the beneficial effects of exercise training are additive to a diet modified in fat content, such as one reduced in total and saturated fat. A low-fat diet will reduce total cholesterol and LDL cholesterol, but may also undesirably decrease HDL cholesterol. Exercise may prevent or attenuate the decrease in HDL cholesterol on such diets, but when combined with omega-3 fatty acid supplementation may actually increase serum HDL cholesterol, as reported in a study by Thomas and others. Thus, the combination of both dietary modification and exercise is the recommended approach to modify favorably serum lipid levels. So, low density forms of lipoproteins may predispose certain individuals to coronary heart disease, whereas high density or HDL forms may be protective. In general, a low to moderate fat diet is recommended for both health and physical performance. One should consume less high-fat meats and dairy products and more fruits, vegetables, whole grain products, dietary fiber, lean meats, and skim milk. Fish, including fatty fish such as salmon, is part of a heart-healthy diet. Diets rich in saturated fats, trans fats, and cholesterol may increase the risk of coronary heart disease. In the United States in general, the recommended dietary intake of total fat is 35% or less of the total caloric intake, with saturated and trans fats at less than 7% of the total. The recommended cholesterol intake is less than 300 milligrams per day or 100 milligrams per 1,000 calories. And lastly, aerobic exercise training increases the ability of the muscles to use fat as an energy source and can be an important adjunct to diet and beneficially modifying the serum lipid profile and reducing body fat. Two factors that may reduce the risk of coronary heart disease, or CHD. Relative to the serum lipid profile, aerobic exercise training is most effective in reducing serum triglycerides and increasing serum HDL cholesterol.